Okay.
Yes, we can hear. Thanks.
Yes, we can hear.
Okay, great. I got a little bit of background noise and I apologize. Let me share my screen and we'll just go ahead and get started with our medical providers update for today. So here, by way of agenda, we'll talk about, some of the county news and actions. Then we'll just dive right in because I'm sure you'll want to hear about influenza trends, COVID-19, RSV, avian influenza, Ebola, monkeypox, some substance use disorder updates, and then also just a call for blood donations. So that's kind of the agenda. Hopefully we'll have time for commentary and questions as well. I think the big picture is really summarized in this slide from the CDC, which is that the whole country is seeing just a large influx of respiratory illnesses. So this includes influenza, but also other respiratory viruses, and probably COVID and RSV, also contributing to this large wave. They break it out by years. So all these colored lines are different years that they've been tracking this. But this year, as you can see, these are the lines along the left with the red triangles, and they kind of speak for themselves. We've got a really high and early season of respiratory illness that is kind of inundating the system and really overwhelming healthcare capacity at so many levels. So I think that's why I just want to open with this slide, that's kind of where things are this week, and will probably stay that way for the next few weeks, taking us into the holidays. And I think throughout the winter, it's going to be very challenging as a result of these numbers being as high as they already are. We triggered and activated our assess and refer policy last week, and that was to help unburden acute care facilities, but also just as a signal to our community that the healthcare system is under tremendous strain, that people really need to make decisions and make sure that their non-emergency care is something that can be taken care of outside of the emergency department. And that really patients should use urgent care centers, telehealth, obviously work with their primary care doctor to get whatever they need to make sure that their complaints taken care of, that they have good advice, but also to recognize that the emergency department is so busy that they may not get normal treatment, especially if they have a non-emergency situation going on. So that's the assess and refer policy. We're continuing to do media. You're going to see a lot of stories locally and at the state and national levels. So we're continuing to do media and community messaging around that. Please help amplify these messages on your social media channels with your conversations with your patients, your staff, and your relatives, and let people know that this is just a really busy time and that everyone needs to, safety is everyone's job. And that can include things like vaccines, which I'll talk about in a little while, using masks, especially around strangers and in higher risk settings like crowded indoor settings where you might be. And really staying home if you're sick and knowing how to get tested and get medications if you come down with something that's treatable, such as COVID or influenza. Please keep your staff healthy. This is a time when we know staff outbreaks can really incapacitate already busy clinical organizations. So just think ahead of time about what you need and what your staff need for success and really try to implement those policies. This is the time to really think through and hopefully dust off things that worked in the past. So that you're not hampered by these outbreaks as they're happening in our community. Influenza. So this is pretty novel because we were really spoiled for the last 2 years that we did not have influenza as a result of really great masking rates and really great vaccination rates for influenza. And we haven't had to deal with influenza in confluence with COVID as well as RSV, but here we are. And California is actually just almost the worst in the country. And you can see that here from this LA Times chart that I was able to just grab online. And that just shows that California is hit very hard to the point where we may run out of antivirals So this is pretty serious, folks. We definitely want to use them to keep people out of the hospital, but we want to use them judiciously and rationally, because that really is a risk that we may run out of the Tamiflu that we know works so well to keep higher risk patients out of the hospitals. With that in mind, I just added a link to the CDC treatment guidance that I hope that you can see. And again, you're going to get all these notes, so hopefully you'll be able to follow along and click on these links yourself. But basically, the CDC has a really nice guidance about not only Tamiflu or oseltamivir, but also 5 other medications that can be used against influenza, depending on if the patient is high risk, lower risk, inpatient, outpatient, et cetera. So I tried to summarize some of that in this section, which I won't belabor over this call, but you can read through it, and then you can look at the bigger CDC document if you want to get more information. But there's the oseltamivir, the zanamivir, the paravimavir, the baloxavir. Again, I don't know in terms of cost issues which one would work for your specific situation or patient, but certainly know about the different options so that you're prepared in case this Tamiflu shortage actually leads to people running out. And I didn't put this in, but please encourage your patients to get their flu vaccination. The flu vaccination seems to be covering the strain that is predominant this winter, and so it is thought to be pretty protective, and at least will keep people out of the hospital, if not completely asymptomatic. So make sure that your patients are getting the flu shots. All right, rolling right along into COVID-19 updates. The major issue that we're seeing is that the hospital numbers are really climbing very quickly. So they've basically tripled in the last couple of weeks or so. And now we're up to 183 patients, right under 200 really, for positive COVID-19 patients in our area hospitals. And that number is, tantamount to the summer surge that we did have. And really it's climbing quickly. So we're really working as best as we can to try to unburden hospitals and get them the breathing room that they need. And just please understand that it's not just COVID-19 that's burdening the hospitals. It's everything. It's the viral infections that we've already discussed. It's the RSV, and then it's everything else that they have to take care of. Every time I work in the emergency department, I'm astounded by 2 things. Number one, how many people do not have their vaccine? And number 2, how many people don't even have COVID and have other things that they need to have to be hospitalized for. So it's not just a single disease issue. It's multiple diseases that are coming into our emergency departments and having to be admitted to our hospitals. And that is creating an excessive burden on our healthcare system. But that being said, there are things we can all do for COVID. So remember, COVID is actually quite treatable now. It's treatable with outpatient oral medications such as Paxlovid and Molnupiravir, and we really need to lower barriers to prescribing these. The state has some great tools in their toolbox now, including this concept of test to treat sites. So we just found out that OptumServe, where a lot of us have sent our patients to get their testing, is actually also a test to treat site. So OptumServe will actually go ahead and initiate a prescription. And they're also doing the same thing for influenza. So with OptumServe, they can actually do both COVID and flu testing and treatments for both COVID and flu. That's a great option to keep people out of the emergency department and to keep people safe, so that they can get tested and treatment in a timely fashion. So please remember that concept. We actually need more people to have that paradigm under their roof. And so I just have a little box here about how you can actually become a test to treat site. Why would you want to do that? Well, basically the state will send you medications and testing supplies. So they will basically get you set up to become a test to treat site. All you have to say is, yes, I'm willing to do it. Provide the information to this email that's in this box, and then we'll get you an account in this database called HPOP. And HPOP is just basically a tracking database for how these medications are used. And we will get you basically on the road to becoming a test to treat site so that you can help treat your own patients, your own staff, basically other folks that want to have a place to go, you can actually be part of that solution. We have urgent cares that are jumping into the mix. We need more folks jumping into the mix. So if you work at an urgent care and you want to know more about how you can do this, then basically please reach out to us. Remember, you can't charge for the medication, but you can pretty much charge for the rest of the visit. The clinical encounter, some of the other testing that you do, you basically, this should be cost neutral for you. And the COVID piece of it, there's actually a lot of good support to make sure that makes sense for your throughput. So please let us help you. Reach out to us if you have any questions about this. We're actually quite good at getting people set up at this point, and the state is committed to doing it in a timely fashion because they understand the need to get it done sooner rather than later. So just keep that in mind, that you should really think about becoming a test to treat site if you're not. And it doesn't matter what size your organization is or what form it is. You could be a pediatrician, you could be a primary internal medicine doctor, family physician, urgent care, etc. We want all hands on deck, and we will work hard to make sure that your information is sent to the state so that you can start to get these medications if you're interested in going in this path and helping out really the whole community. Vaccines still work. Unfortunately, our numbers are super low with the bivalent boosters. So as of today, actually, bivalent boosters have been approved for ages down to 6 months of age. And that just came out today in a press release from the FDA. And these bivalent boosters are the best vaccines people can get. So if you haven't had one yet, you should rush out and go get it. And anyone down to 6 months of age can now get a bivalent booster. And that really protects you against some of these novel strains that are still related to Omicron. And that's coming out in MMWR publications, which is what this top link is. And then the FDA press releases are included in this link under item D. And there's actually a CDC webinar coming up next week to talk about this and how to educate patients about it. So I urge you to tune into that. The CDC always gets these national experts to explain the science and the messaging related to so much of the pandemic response. And here they're dedicating a whole hour on bivalent vaccines and what we need to know about getting more people vaccinated. In terms of the numbers, we're barely touching 11%. When we look at the total number of eligible folks that should get their bivalent booster. Many people got the original vaccines and thought they were done, and I wish that were the case. But even when people get the original vaccines, they still need to go back and get their bivalent booster to be truly protected this winter season. So that's a little pearl that you just need to put out into your conversations with just about everyone to say, you know what, I'm glad you got your original vaccine. I'm really glad that you did that. But now it's time to go back and get this booster shot because otherwise you're not going to be protected. And the same thing for people that survived COVID. They think that they're immune because they had the original COVID or because they had COVID later than that. And it turns out that, those folks should still go ahead and get their bivalent booster. That's really the best way to keep people protected. And then just some information and talking points about why patients should get the COVID treatment. Really, the Paxlovid is, something of a miracle drug because it's really shown to reduce hospitalization and death by up to 88%. People who take Paxlovid are up to 8 times less likely to need hospitalizations and 10 times less likely to die from COVID. And really, all of the 183 patients that we had in our hospitals, the folks that we had to admit, really, a bunch of those folks should have gotten Paxlovid, honestly. And so there's, as long as you give people Paxlovid earlier in the course of their disease, you can really prevent hospitalizations. And so it's really behooves all of us to let our patients know that just because they get COVID and they don't feel that sick, they should still get Paxlovid. Almost everyone is eligible. It can really prevent the virus from multiplying and infecting other people, but also it can keep people out of the hospital in those early days. It has to be given within the first 5 to 7 days, even before somebody has severe complications. And so just keep that in mind that if they are at higher risk, even if they're at medium risk, there's enough supply in the system to where almost everyone that gets COVID should really just be getting an oral antiviral at this point. And that way they can stay assured that they will have a quicker recovery, a quicker negative test, and stay out of the hospital. So that's another big message that the state is encouraging everyone to kind of incorporate. Don't wait until your illness gets worse. get treatment while your illness is mild. All right, let's keep talking about more viral infections. This is a slide from LA County, but I think it tells a story that's going on almost all across the state. And that is that RSV specimens are still very high, but they may be leveling off. So we may have seen the peak of RSV. Let's all hope so. Cross our fingers. We know that it sometimes has a bimodal peak, which you can sort of see here in the purple line, but pretty much for what it's worth, people think that we are seeing RSV as worse as it's going to get. It's still very high. It still hasn't abated yet, but it's not climbing, which I suppose is the best piece of news that that I have to share about all of these viral pandemics. But we know that people are still struggling to understand what it is. Because we really haven't had to deal with it at this level, that a lot of patients are coming into kind of unconventional places, such as urgent care centers and emergency departments where adult clinicians may be asked to see very young patients, or elderly patients are just getting RSV as well. So there's a great article from the American Association of Family Physicians about outpatient management of bronchiolitis. And so I linked that for you to look at. And then there's some other great documents that are being worked on from CDPH and the American Academy of Pediatrics about what to do with RSV patients and really which high-risk patients qualify for an antibody treatment called Synagis, which can prevent RSV and severe RSV complications in high-risk babies. And so, you know, if you're a pediatrician that treats high-risk babies or a family physician, et cetera, then you basically should know about Synagis and refer patients to get it because that will protect them. And those are the really high-risk, vulnerable populations that we want to protect. So those 3 links are included for you is, you know, general guidance, CDPH guidance related to this season, and then basically AAP guidance on Synagis. And I can answer any other questions about RSV, but I think you've probably heard enough stories about RSV at this point to where you kind of understand that it's an issue. Most cases are going to be mild and treated on the outpatient side. Very few high-risk patients will need to be hospitalized for nebulizer treatment, oxygen treatment, invasive ventilation, et cetera. Thankfully, that's a very small number, but it's still big enough to where it's overwhelming our children's colleagues and our pediatric colleagues in all the hospitals. And so we need to all do whatever we can to make sure that we're triaging properly and preventing as much as possible. And letting parents know about, you know, bulb suctioning at home, hydrating and making sure that the child is able to maintain oral fluids and temperature control, et cetera, so that these kids don't get sicker than they need to be while they're fighting this RSV infection. All right, let me stop there. I'll go through the chat, see if there's any questions, and then I'll move on. So Naomi's asking what the schedule is. And from what I understand, yes, the schedule is still the same, but the dosing is different. And so you can look on the FDA guidance to see how that changes. They actually have different vials, different syringes, all of that stuff for pediatric doses. But from what I understand, the schedule is still the same for these bivalent vaccines. And then Rachel's asking, is the test to treat just for COVID or influenza as well? From what I understand, it's, excuse me, just for COVID. Although if you're having trouble getting influenza tests, then you can also email that same email, the Mohawk email. That's the general email that we use for any resource requests, whether it's, you know, human resources like extra nurses and extra personnel, to materials resources like PPE and masks and stuff like that, or testing and medication resources. It's all one email that then gets triaged to different agencies across the state, but that's how these requests should come in. So really whatever you need, if you're seeing just a lot of influenza patients and you want to have point of care influenza testing, then email the Mohawk and they can try to track down some of those tests for you. All right. Lots of other good comments. Really appreciate everyone sharing what they're seeing. I know that it's just a very busy time, and that the instinct is to send kids to the ED. But please understand that that may not be the best place for them. We actually are working on an advisory related to urgent cares. So Sim and Sonia and the rest of the team have done such a fantastic job. They've actually called like every urgent care in the county to say, what are your hours? Are you open? Are you still functioning? Are you interested in test to treat? And we're basically going to bundle that into a resource for everyone so that like which urgent cares are available to send your patients to. And they should be able to help offload some of this burden off of the primary care physicians and the emergency departments. And in terms of just like staying open later, that's something that everyone should really be thinking about doing and trying to make happen. I know that that's very hard, but the EDs really are at capacity. And if the EDs go down, then we just lose such a critical component of our healthcare system. And if we can just offload some of that volume by accepting just a few more patients in our day, by staying open an hour or two later, by doing a few more tests just in our own organizations, that really helps all across the system if everyone just helps pitch in a little bit. So think about the giving just an extra 2 to 5% and just pitching in a little bit. If everybody did that, then I think we could get a lot more resources and places for patients to go to in the healthcare system. And I think that would help tremendously because right now, we're on the cusp of basically declaring an emergency and doing even more than the assess and refer. That's basically the kinds of conversations that we're having. And don't quote me on that because we're not ready to do that just yet, but that's basically where we would have to go if things get worse. And the way these trends are looking, even though I don't have a crystal ball, I can't imagine that they're going to get better between now and Christmas. Okay. All right, let's keep going, and then we'll open it up for more comments because I have a few more items to share. These may not be as urgent or as headline grabbing, but they are kind of important, and this just goes to show you kind of the depth and talent of the team that I work with. I'm so proud of them. So at Public Health, we've quietly been actually responding to some avian influenza, I would say exposures. Not cases. We haven't documented any cases yet, but we've actually had several different exposures, kind of like the one that you see summarized here. And that is that, this highly pathogenic avian influenza is circulating among birds in North America. We've seen it in commercial flocks. We've seen it in many different species, ducks, geese, chickens, wild animals, commercial animals, even backyard clusters that people might have. And so we're actually quite experienced. The communicable disease team is quite experienced at identifying who the human contacts are, and basically making sure that they have all the information that they need, that they're getting monitored on a daily basis for any symptoms that might be influenza, and then that they're getting tested. There's no vaccine against this. And this, although it is an influenza species, requires a special kind of testing. So you can't just do a good old, flu swab on these folks. And so all of that requires a little bit more coordination than just sending them into like an emergency department, which, as you can imagine, is like a terrible idea for so many reasons. And so we basically want them to, get the diagnosis that they need, get the monitoring that they need, and get the treatment if they need it. The only really good piece of good news is that it's really hard to spread this from person to person. And so it's relatively less contagious than human influenza, which is what's grabbing all the headlines. However, these folks might get sick, as individuals, and so they do need a lot of attention. And so we're continuing to work with the Department of Agriculture. They're the ones that actually go through and, I'll be frank, they kill all the animals that are involved. But then, the folks that have to do all that euthanasia, as it were, and then the cleanup are at really high risk, and so they require a period of monitoring even after I think it's called culling the herd or something like that. After that culling event is done, those employees have to be monitored. The reason that I'm sharing this is some of you may treat these folks, and you may or may not know that this is where this person works. If their flu-like illness, presents as a presentation of this, it's going to look a lot like regular influenza or even COVID or other viral infections. And so you're going to need to ask, like, where do you work? Let's talk about, is this a valid exposure? And if they tell you, hopefully we've given them enough education and they're literate enough to share that they are part of this biomonitoring program. But again, things could fall through the cracks. But just have this situational awareness that exposure to birds in an occupational setting combined with influenza-like illness is, that should set off alarm bells. Call us and we'll give you further guidance about what to do. Just keep in mind that they're at relatively low risk to you and your staff, although we want them to get good care. And obviously, for reasons of epidemiology, we want to know if they have, avian influenza. We haven't had a single human case that I'm aware of in our county, although it is described and well described worldwide. So this is why we are enhancing our protocols around this, is because our partners at the U.S. Department of Agriculture and the County Department of Agriculture share these scenarios with us, and we're in regular communication with them. All right, more monitoring. So we're also doing monitoring on travelers that have come from areas of outbreak associated with Ebola virus disease. So you've probably heard about this. It's been going on for several months at this point. There's been actually a lot of fatalities in Africa. And whenever travelers come back from that region, they're monitored all along the way, at the airport. And then after they leave the airport, if they're asymptomatic, they're asked to stay home and kind of monitor themselves, et cetera. And our team actually contacts them to make sure that they remain asymptomatic for a period of time, usually 2 to 3 weeks. That's the incubation period. And, if they become symptomatic, then we basically want to direct them. And this one is contagious, unfortunately. So we want to be really careful with how they're directed and make sure that our receiving facilities like the emergency department have good protocols in place. But again, situational awareness requires all of us just understand what this disease is and ask about it, especially if they have a travel from Africa or from a high-risk area or contact with someone who's been diagnosed with Ebola. Then you really want to be very, very cognizant of the risk, especially when they have flu-like illness, fever, or even severe sepsis syndrome. Just keep in mind that it's been going on. If you haven't heard about it, then it's basically because it really hasn't risen to the level of an actual case locally, although it's actually being monitored all over the country, just wherever these patients end up going to. And so we've had several of these patients come into our county, and so far they've all remained asymptomatic. And so we're working with our partners to figure out what the best protocols are. And our emergency departments are also aware about this situation and have, again, reviewed their protocols so that they know exactly what to do if they get that phone call that there is a patient with, active or suspected or presumed Ebola that's going to come their way. The emergency departments have, a protocol already made for how to handle and receive those patients so that they're not exposing the rest of the staff and the rest of the patients in that facility. All right, and then one last one is Mpox. I think that's the new name. Apparently the name has changed and cases are still being diagnosed, although it seems like the velocity has really tapered off. So they're not being diagnosed as frequently, but they still continue to occur. There's more and more science coming out about, who the high-risk patients are. And it's very evident that immunocompromised patients and those with comorbid illnesses, HIV illness, for example, are at super high risk. And so those are the patients that really deserve to have aggressive preventative health care, such as the vaccination, and also post-infection care with the investigational drug called tecovirimat, which is available in our county. You've heard me talk about that before. So if you have patients with just suspected Mpox, then basically reach out to us if you need any help. We've done this, a bunch of times at this point. I think our count is around 60 at this point in the county of Fresno. And many of those patients have actually been treated with tecovirimat and been kept out of the hospital for that reason. So we know that that's a very effective medication. We just think that there still needs to be that vigilance that we need to get patients that are at high risk to get the vaccine. And then for those who didn't get the vaccine, or for those who actually come down with the infection of Mpox, they basically should go ahead and know about the TPOXX medication, tecovirimat. It's actually a smallpox antiviral, but it's actually investigationally being used for Mpox because there's really nothing else available, but it works really well. All right, now let me pass the microphone to my good friend, Christopher Staub. Chris, tell us about the situation at the Blood Center and how all of us on this call can help assist your organization with saving lives.
Thanks, Dr. Vohra. Hi, everyone. So for about 6 months or so, you really didn't hear too much from me, and that's because the blood supply was doing fairly well. But sure enough, it's holiday time, winter time. Donors are getting sick and unable to donate. And so we're once again in a bit of a situation where we have a less than 1 day supply of blood in our blood bank. Now, the hospitals have a little bit of a buffer, but it's not more than a day or two. And so it's very important that you come to one of our centers and donate blood. We need all blood types right now. Normally I say especially O negative, but I'll say especially everything right now. And so please come to one of our locations and donate blood, and urge your friends and family to do the same. We need a real big turnout in the next week to really kind of get the supply in a good position as we head towards the holidays at the end of the month. But the other thing, Dr. Vohra, I wanted to ask is, are there any folks on this call from the state emergency management by any chance? Maybe not, right?
I'm not aware of them, but please speak up if you are. We certainly have our county emergency management folks that.
Okay, maybe not. So, but I learned something interesting this morning. I was on a statewide blood bank meeting. The group is called Blood Banks of California. And that group was made aware that there is really no process in place with the state emergency management organizations to link them to the blood banks of the state. And so we have, the blood banks have some linkage in their local county health departments, like we do with Fresno County, for example. But statewide, that it's a deficiency in the sense that we have not had that emergency management group connected to our statewide blood bank network. And so as BCC, Blood Centers of California, are going to be working on that in the new year to reach out to the state and make sure that we have, we set up formal channels of communication for emergency management where blood may be needed in the future. And just FYI. And that's all I have.
Great. Thanks, Chris. Any questions for Chris? Hopefully that link is the right one. I just went to donateblood.org.
Yes.
They have a wonderful website, and that allows people to get set up to donate.
Hey, Dr. Vohra, this is Dan Lynch. I'll have our OES staff get hold of Chris and follow up with him on
Perfect.
this situation. So,
Thank you.
thanks.
Thank you, Dan.
Okay. Great. Thank you. All right. Well, I couldn't let you guys go without talking about substance use disorders, but I actually have some great news to share, not gloom and doom, about the opioid overdose epidemic. So a couple of things have happened since the last time we met, and I think that again, for situational awareness, I want to share this in case it applies to you. So first, our state health officer, Dr. Tomas Aragon, actually crafted a letter to all hospital administrators. And they basically, he asked them to really think about the opioid epidemic and to take steps to help make a difference. There's several things that he recommended. I'm so glad to say that many of our hospitals are actually doing it. So first, applying for the bridge program funding and hiring navigators who can actually work one-on-one with patients that are struggling with drug addiction. So almost all of our facilities in the county are doing it. If you're not, or if you don't know about the bridge program, this is free funding from the state to help you hire a substance use navigator and support clinicians who want to help promote best practices related to drug overdose and opioid addiction. So that's one big activity. The other activity is, hand out Narcan. The state provides free Narcan through a distribution grant, and that can be given free of charge to our patients and their families. And they are so grateful just to have that extra layer of protection. I like to say that Narcan is like a seatbelt. You should always use it, and you should always pray that you never need to use it. And that's basically what Narcan is you shouldn't plan to use it. You should really make choices in your life to where you never need to use it. However, we know that people's lives are complicated, that they may engage in higher risk activities, or they may be on very powerful medications for pain conditions, et cetera. And then having that naloxone handy, even before the EMS arrives, can save a life. And so again, it's like a seatbelt. It's not plan A, it's more like plan B. However, sometimes plan A fails and you have to have a plan B. And so Narcan needs to be part of that conversation and part of that solution. And then the other thing that happened is the state actually passed legislation that all facilities have to test for fentanyl. Now, this seems minor, but this is actually was a big barrier and a big blind spot for us because fentanyl did not show up on urine drug screens. So we were really flying blind whenever we had a patient with, unknown altered mental status or a drug overdose, and they didn't know what they took. We weren't able to document that fentanyl was actually in their system, and now we can, or now, hospitals will need to offer that as part of their urine drug screen. So again, if you're working at a hospital, a general acute care facility, as it's called, GACH, then you will need to comply with this state law. And I know that the hospitals that I work with are already doing it. So that's great. For other hospitals, just keep that in mind that this kind of quietly passed in late November, but that it's out there. And if you need more information about it, here's a link. It's actually not hard to do. You could just contact your lab or work with your lab director and get this fentanyl added into the urine drug screen. We're already testing for a lot of other, types of substances, but fentanyl was not one of them. It doesn't show up with the opioid drug screen because it's synthetically a little bit different in terms of its molecular structure. But now we'll need to be testing for fentanyl in all of our hospitals. So I thought that was a good piece of news. And while it won't get every single opioid that's out there and poisoning people, it will actually will be a way for us to look for fentanyl, which we know is a major problem. And then, there's lots of trainings that you can actually access through the Bridge website. And I just put in a link for that. These are webinars by experts statewide and nationwide. And I really urge you to check in and see which topics fit your clinical practice. If you don't know where to start at all, just start watching these videos. I mean, you can do it from the comfort of your own home, and you will quickly learn the best practices that can help save lives. And perhaps even equally importantly, you'll actually work more efficiently. So I say work smarter, not harder. If you don't know about MAT, medication-assisted treatment, if you don't know about addiction medicine, best practice updates, you're actually working too hard on addiction issues, which we know are coming to you. Lots and lots of patients have these issues. 1 out of every 9 hospitalized patients has a substance use disorder, and not enough clinicians are up to date about how to treat them efficiently and get them referred into services. And that's basically the whole point of the Bridge program, is to say, let's work smarter, not harder. We can actually be more efficient about this, and we can actually save lives and make everybody's lives better. And lastly, Dr. Linscheid was so great in developing not only the print materials that I'm going to share, but she's actually heading a perinatal substance use task force, which really brings together multiple different agencies, multiple different disciplines, just to care for pregnant women in Fresno County and surrounding counties that are struggling with substance use disorder. And this is just one of the graphics that her team has able to come up with. It's now posted on our website. It can also be given in the form of a brochure to your patients. And it basically has lots of great information. First, the graphic itself is just so amazing just to see. And then it basically has phone numbers and websites and good information that pregnant women and families need to know about where to get help so that they can not feel isolated and alone and not lose hope. There's actually just tons of different resources available and treatment centers available. And all of that is available in the form of a poster or a brochure that you can share with your patients. So those are the last two links on my document. Please click on those, print them out, distribute them, leave them in your lobby, give them to your staff, put them up on your walls, all of the above. And this will hopefully help really, again, put another dent in this opioid epidemic, especially in our pregnant patients who often struggle alone because pregnancy is seen as a different disease, and addiction is seen as a different disease, and people sometimes don't put the two together. But we actually have quite a few patients that have both of those issues. I guess I shouldn't call pregnancy a disease. That's just my paternalistic attitude. But pregnancy is treated by a different set of professionals than addiction, and it's time that these patients can get help all in one place. And that's basically the point of the perinatal substance use task force. And you can learn more about that from Dr. Lynn Scheidt. And we'll have more stuff on our website about that. If you're interested in this issue, please reach out to us and we'll get you connected with Dr. Lynn Scheidt. In the meantime, look at these materials because I'm sure you will get a lot out of them. They fill a very important need in our community. So thanks so much for getting those developed to Dr. Lynn Scheidt. And that's really all I have. Let me look on the chat to see. Oh, great. Thanks, Dr. Mitchell. That's great. The substance use navigators at CRMC. There's actually navigators now at CRMC, Clovis, Kaiser, St. Agnes. Who am I leaving out? The Adventist hospitals, Madera Community, and they're all teaching each other best practices. So it really warms my heart that we're doing something that's so positive and affecting so many people. And they're really wonderful people that can actually make huge, significant impacts in patients' lives. And then they actually do a lot of education, like Dr. Mitchell is saying, to train the Student Health Center for things around Narcan, for how to start medication-assisted treatment. And you've heard me say this before, every prescriber needs to get their X waiver. Please get your X waiver. It only takes 3 to 5 minutes, and then you can actually start prescribing buprenorphine, which is a life-saving medication. Oh, and Dr. Lynn Scheidt is on. So sorry, you can go ahead and speak up if you want. Sorry if I spoke out of turn or said anything that was off.
No, that was great. Thank you. Thank you, Dr. Vohra. We just met at the task force yesterday, and some really great connections that we're making and building, and really trying to, one thing that kind of came up over and over again, and recently I know Dr. Zweifler was working on this particular patient, was just getting patients into OB care that we interact with either at the needle exchange or our MAT sites, and finding OBs that I know we're just short on providers in general, but really just finding someone they can see quickly. And so our task force is really trying to work on that outpatient linkage, and that's one thing that the hospitals are seeing, that we're seeing just kind of across the board. And so we're looking for some clinics or offices, providers that maybe we can work with to, like you said, if we can just beef up maybe 2%, extra, if we had several providers that could see just a couple patients on an more urgent referral system, that would go a long way. So please contact me if you're interested at all.
Yeah, and thank you so much, Robin. I really appreciate everything that you do. And once you start doing MAT, you'll see it's not hard. I mean, it really, you are doing so much more complicated patient care for many other disease processes. Opioid addiction is actually super easy to treat once you know about buprenorphine. and just how easy it is to give to people, how well they respond to it, how good they feel, and how much they recover very quickly. So it's not hard to do at all. It's not complicated. We just have this federal requirement of the X waiver, which makes it seem kind of daunting and scary. But once you get your X waiver, really anyone can start prescribing the buprenorphine or the Suboxone. And it's really not hard. It really turns people's lives around. So that's why I'm so passionate about this, because I see this as a super low hanging fruit, and really every provider in the county should be doing it.
Yeah, and also for pregnancy, buprenorphine is really the gold standard now. We used to do methadone, and the data really is coming out saying
Yeah.
buprenorphine is the way to go. You can treat it outpatient basis, and from a provider who just recently started prescribing and doing this, like, I understand that hesitancy, but there are resources like with California Bridge, with Dr. Vohra. There are a lot of mentorship programs that if you're nervous about it, to help you walk through that first patient. And once you get through that first patient, I mean, it really is easy, you know, and then you look back and think, how did I ever prescribe opioids and feel comfortable with that and not comfortable with buprenorphine? Because really, we should be as comfortable with that, or even more comfortable prescribing buprenorphine, because it really is that easy.
Yeah, there was a trial that just came out like this week or last week in the New England Journal that I just shared in the chat. And it basically just shows that, you know, both buprenorphine and methadone are very effective for keeping patients off of street drugs, but buprenorphine actually helps with the neonatal outcomes. And those babies are just kind of more robust and do better if the mom has been on buprenorphine. So again, just adds to the robust body of evidence at this point that buprenorphine in pregnancy is safe and effective, and just leads to healthier pregnancy outcomes. Great. Any other questions? Thank you again, Robin. Really appreciate all that you're doing. All right, well, we'll go ahead and adjourn, and hopefully all of you have learned a little bit today. I will send out these notes this afternoon, so please look for those in your inbox, and I'm sure we will meet again before the end of the year. In the meantime, please stay safe, really take these messages to heart, and start incorporating some of these safety procedures if you haven't already, and reach out to us if we can help support you in any way. I know it's a busy time. I know it's a time when you might feel challenged and strained. We want to hear from you about anything that we can help with. And we wish you utmost success and have a great afternoon. Thank you.
Thank you, Dr. Vohra.
Take care. Bye.